Bismillahirrahmanirrahim. Quote for today is patience is bitter, but its fruit is sweet. Today I am doing the critical appraisal of an article under the supervision of my professor Dr. Saira Afzal from the Department of Community Medicine, SPGR there. This is the consort checklist that is I'm going to apply. This list was applies on randomized trials and it includes different sections, topics, and it gives checklist items. This is the topic of the article that I'm going to appraise critically. A randomized controlled trial to test the effectiveness of two technology enhanced diabetes prevention programs in primary care. The diabetic study. This is the abstract of the article that shows in the objective to evaluate the effectiveness of two technology enhanced interventions for diabetes prevention among adults at risk for developing diabetes in a primary care setting. Regarding methodology, in the abstract, the diabetes study employed a hybrid two-group preferences, choice and three-group randomized controlled trial design. This paper presents weight-related primary outcome of the RCT arm. Patients from Southwest Virginia were identified through the Carillon Clinic electronic health records. Eligible participants identified through the Carillon Clinic electronic health records. Eligible participants were 18 and older BMI or whose BMI were more than or equal to 25, no type 2 diabetes were randomized to either choice or RCT. Individuals were further randomized to one of the three groups. One is 2H small groups class to help patients develop a personal action plan to prevent diabetes. Second group is 2H small group plus automated telephone calls using an interactive voice response system, that is IVR, to help participants initiate weight loss through healthful diet and regular physical activity. And third is a DVD with same content as the class plus the same IVR calls over a period of 12 months. Results of the 333 participants that were randomized, 232 had study measured weight at 6 months, at 12 months, and 208 at 18 months. Class or IVR participants were less likely to complete weight measures than the SC and DVD or IVR persons. Intentions to treat analysis controlling for gender, race, and age baseline BMI showed that it led to reductions in the BMI at 6. All three groups showed a significant number of participants losing at least 5% of their body weight at 12 months. Now, title and abstract according to the consort checklist. First point according to the consort checklist is identification as a randomized trial in the title. This point is followed because it was mentioned as I already told. Second is structured summary of the trial design, method, results, and conclusion. According to the consort checklist, the title adequately describes the study and the abstract provides a concise overview of the research objectives, methods, and results and conclusion. So this point was also followed. Now from the introduction, I've given just a paragraph. The Center for the Disease Control and Prevention estimates that there are 34.2 million Americans with diabetes, in addition to 88 million of the population with pre-diabetes in the United States, and strongly recommends healthcare approaches to prevent diabetes. The purpose of the present paper is to evaluate the effectiveness of two technology enhanced interventions in supporting patients to reduce their body mass index over an 18 months period. Relative to a minimal standard care intervention, we hypothesized that compared to minimal standard care, each intervention would result in greater mean reduction in BMI over 18 months. And from methodology, I've also added a few lines. Patients at risk for developing diabetes were randomly assigned by the project manager to either an RCT or choice study arm using blocked randomization tables stratified by sex created by study stratification. Potential participants were initially identified through a Carillon Clinic electronic health record inquiry of primary care patients between January 2014 and August 2015. Eligibility criteria included patients that over the previous 12 months were 18 years of age and older or BMI more than or equal to 25. Had ICD-9 codes for pre-diabetes, glucose tolerance, intolerance, metabolic syndrome, or obesity, while excluding those with the ICD-9 codes indicating diagnosed diabetes, congestive heart failure, and coronary artery disease. Now, introduction and background and objectives according to consort checklist. According to the consort checklist, scientific background and explanation of the rationale. The introduction provides scientific background information on the importance of diabetes prevention and rationale for conducting the study. This point is clearly followed in the introduction. Then, second point is specific objective or hypothesis. As I already told in the lines, this point is also being followed. Regarding the methodology in the consort checklist, trial design, that is description of the trial design, including allocation ratios given. This point was not completely followed in the methodology. Third is important changes to methods after trial commencement, such as eligibility criteria with reasons. This point was not followed because there were no changes made after the trial commencement. Participants. Eligibility criteria for the participants. This point was followed because it was given. Next is settings and location where the data were collected. This point is also followed in the article. Regarding the interventions, I'm just telling a few lines from the article. Regarding standard care, participants in the standard care comparison group took part in a 2H small group session class taught by two trained Carillon clinic employees. This class has been offered for the past 6 years and dietitians. Although they are available to call all the Carillon clinic patients for the purpose of the project, separate class to each intervention group were offered. As such, both groups attended project-specific classes for the given study group. The content, format, and visual teaching these classes did not differ from currently taught classes. Mm. Now, according to the consort checklist in the interventions for each group with sufficient details to allow replication, including how and when they were actually administered. This point is followed. In the outcome, completely defined pre-specified primary and secondary outcome measures, including how and when they were assessed. This point is also being followed in the article. Regarding outcome, any change to trial outcome after the trial commencement with reasons. No change was made in the study, so this point was also not being followed. Sample size, how the sample size was determined. This point is not cleared. When applicable, explanation of any interim analysis and stopping guidelines. This point is also not given in the article. In the interventions, patients at risk for developing diabetes were randomly assigned by the project manager to either an RCT or choice study arm. Randomization table stratified by sex created by the study stratification. Patients in the RCT arm were further randomized 1-1-1 to one of the three groups. Now, randomization according to the consort checklist. Methods used to generate the random allocation sequence. This point was followed. Type of randomization, details of any restrictions such as blocking, block size, allocation, concealment. The article mentions randomization, but it is unclear how the process was conducted and whether allocation concealment was implemented to prevent selection bias or not. In the mechanism used to implement the random allocation sequence, such as sequentially numbered containers, this point was followed. Describing steps taken to conceal the sequence until interventions are assigned, this point is not followed. In the implementation, who generated the random allocation sequence, who enrolled participants, and who assigned participants to interventions. This point is followed. Regarding blinding, if done, who was blinded after assignment to intervention? This point was not clearly stated in the article. If relevant, description of similarity of interventions, because the blinding was not explained, so this point is also not relevant. Now coming towards the statistical analysis. Statistical analysis included descriptive statistics for age, sex, race, ethnicity, education, income, health literacy, employment, health insurance, diabetes risk calculators, and weight status. Chi-square independent t-tests were conducted to determine if any of the groups differed on baseline characteristics. Data were examined for the presence of outliers, violations of normality, for those continuous variables, and missing data. Statistical methods according to consort checklist. Statistical methods used to compare groups for primary and secondary outcomes. This point was followed. Methods for additional analysis such as subgroup analysis and adjusted analysis. This point was also followed. In the results, participants flow, a diagram is strongly recommended. This point is not followed. For each group, the number of participants who were randomly assigned received intended treatment and were analyzed for the primary outcome. The results section provides clear summaries of the main findings, including both quantitative and qualitative insight. However, additional information on the participants' flow was not given. For each group, losses and exclusion after randomization together with reasons. No such thing is mentioned in the study. According to the consort checklist, recruitment dates defining the period of recruitment and follow, why the trial ended or was stopped. This point is not followed. A table showing baseline demographic and clinical characteristics for each group. This point was also not seen. For each group, number of participants denominated included in each analysis and whether analysis was assigned by the original assigned groups. This was not clearly mentioned. Outcomes and estimation. For each primary and secondary outcome, results for each group and the estimated effect size and its precision, such as 95% confidence interval, this point is followed. For binary outcomes presentation for both absolute and relative effect size is not recommended. This point is also not clearly followed. Regarding outcome measures, the primary outcome was changed in BMI from baseline to 18 months. Secondary outcomes included percentage of participants achieving weight loss goals of 5% or more, changes in percent weight reduction, as well as maintenance of those changes at 12 and 18 months. Height was assessed in stocking feet with calibrated stadiometer with fixed vertical backboard and adjustable headboard. Now, ancillary analysis according to the consort checklist. Results of any other analysis performed included subgroups analysis and adjusted analysis distinguishing pre-specified from exploratory harms. The results section provides clear summaries of the findings. However, additional information of the participant flow and nutrition rate would have enhanced transparency. All important harms or unintended effects of each group, this point was not followed in the article. A little paragraph from discussion is the randomized trial arm of our study demonstrated that two technology enhanced diabetes prevention program both led to modest reduction in the weight of the body over an 18 months period. Most importantly, the DVD group showed a significant reduction in the BMI when compared to the sequence group, confirming our original hypothesis. However, there were no significant difference between the class and other groups. Participants in the DVD IVR groups lost a mean of 2.79 kg weight over 12 months, with 26.9% of the participants losing 5% or more of their initial weight in the ITT analysis. Now, points in the discussion according to consort checklist, trial limitation addressing source of potential bias, imprecision, and if relevant, multiplicity of analysis. This point is not followed clearly in the discussion section. Regarding the generalizability, external validity, applicability of the trial findings, this point was followed. And interpretation consistent with the results, balancing benefits and harms, and considering other relevant evidences. With results, it was followed while not with the benefits and harms. Discussion according to consort checklist interprets the results in light of the study objectives and previous research. However, strengths and limitations of the study are acknowledged, but there may be opportunities to explore the implication of the findings in more depth. This shows the conclusion of the study registration and keywords. Regarding registration number and the trial of the study registry should be given according to consort checklist, and this point is followed. Regarding protocol, the full trial protocol can be assessed if available. This is followed. Source of the funding and other support, role of funders, this is also followed. Now, strengths of the article, according to me, are the study design. The use of randomized trial design is a significant strength and is a gold standard for evaluating the effectiveness of intervention. Study addresses a pressing public health issue. Innovative interventions are given, clear reporting was done, and the findings of the study have direct clinical implications. Weaknesses of the study are incomplete methodological information. The article lacks detailed information on certain methodological aspects such as randomization procedure, blinding, and allocation concealment. There were limited participant characteristics, insufficient details on how outcomes were assessed, potential for bias was not completely addressed, however, limited discussion of limitations. Thank you.